Hi, my name is Kate Suslovich, and I'm one of the Utah Emergency Medicine residents. I'll be talking to you today about ectopic pregnancy. This is an important topic because it's the leading cause of maternal death in the first trimester of pregnancy. It represents about 2% of all pregnancies, but the prevalence is as high as 15% of women presenting for abdominal pain or vaginal bleeding. The incidence of this condition is actually increasing, but mortality is decreasing, thanks in part to increased provider awareness and better imaging modalities in the form of ultrasound. So the technical definition of this condition is a pregnancy in which the blastocyst develops outside of the uterus. Trophoblastic invasion, otherwise known as implantation, can cause ischemic changes in vascular erosion. It most likely happens because of a delayed passage of the fertilized ovum due to damaged ciliated epithelium and peristaltic activity of the myosalpinx. The most common location is at the ampulla, but technically this can be anywhere in the abdomen, not just in the GU system. It's important to remember that most women presenting for ectopic pregnancy actually have no risk factors, but there are some risk factors that are worth going through just because they should increase your index of suspicion. So specifically, a history of IVF or other assisted reproduction techniques, an IUD either placed during the time of conception or previously, prior tubal surgeries including tubal ligations, pelvic inflammatory disease or a history of chlamydia. Previous ectopic pregnancies is particularly important because of those women who are able to get pregnant again, 30% will have another ectopic. And then less well-studied risk factors including smoking greater than a pack a day, prior spontaneous or induced abortions, and advanced maternal age. So what will this patient look like when she comes in? It's hard to say exactly, but the classic triad is abdominal pain, light vaginal bleeding, and amenorrhea, or a missed period. I say it's hard to say because 25% of patients will actually lack this triad, 90% will have pain, 80% will have vaginal bleeding, 70% will have amenorrhea, but 10% will be totally asymptomatic. Because of that, you have to keep a broad differential diagnosis. And this will also depend on which symptoms they present with. You should consider other forms of spontaneous abortion, including complete, incomplete, inevitable, missed, septic, or threatened, as well as gestational trophoblastic disease in a molar pregnancy. This might also be implantation bleeding or non-pregnancy related causes such as cervicitis or fibroids. I put this picture on the slide as a reminder that pregnant women are still susceptible to all of the abdominal pathologies that anyone else can get. So you should still consider UTI, pyelonephritis, appendicitis, nephrolithiasis, a TOA, ovarian cyst rupture, endometriosis, or PID in your differential. In terms of workup, it'll be important to get a really good history, both a general medical history and a specific OB history. Particularly high-yield questions will be about pain, bleeding, and prior episodes, both during this pregnancy and prior pregnancies. You might also consider asking about other times she's had similar symptoms when she didn't know she was pregnant, as that might have been a missed ectopic or a missed pregnancy. You should definitely ask about infertility and IVF treatment, and then the risk factors that we just discussed. Finally, I'm sure you would have done this anyway, but you should characterize all of her symptoms to be complete. In terms of physical exam, you should really focus on the hemodynamic status, but I'll warn you that some women will be really hiding more acute pathology than you might initially realize. I say that because some women can lose up to 2 liters of blood into their pelvis and still have stable vital signs, or actually may even have paradoxical bradycardia. So you should expect to see a variable presentation in terms of vital signs, and then you should do an abdominal as well as a pelvic and speculum exam for other symptoms of ectopic pregnancy. Keep in mind that no one symptom can make or break this diagnosis. So if you don't see peritonitis, cervical motion tenderness, an adnexal mass or tenderness, or bleeding on your speculum exam, that doesn't actually rule out ectopic pregnancy. In terms of labs that might be helpful for you, a CBC, a type and screen, or a type and cross if your patient is unstable, with RH factor, a beta HCG, preferably a serum quant over a urine pregnancy test, and a progesterone level. I just want to say a few words about the beta HCG. There used to be a belief that if the beta HCG was less than 1,000, it was safe to rule out ectopic pregnancy. That is not true. Any woman of childbearing age might have an ectopic pregnancy. On the flip side, beta HCG is helpful for two reasons. If the level is greater than 3,000 and you do an ultrasound but do not see an intrauterine pregnancy, that is highly suggestive of ectopic pregnancy. The other reason it's worth checking is because you can trend this level. If the initial level is less than 2,000, you should check for a doubling time. If the rise is less than 66% in 48 hours, that indicates ectopic or non-viable intrauterine pregnancy. I also put progesterone on this list. It's possible, this is not available in every ED, but if it is possible, a normal value greater than 25 is greater than 25. If it's less than 15, that suggests an ectopic pregnancy, and if it's less than 5, it's non-viable regardless of the location of the pregnancy. Because a delay in diagnosis is a huge factor for morbidity and mortality of this otherwise fairly healthy population, researchers have really focused on ways we could expedite diagnosis. I won't read you all of the factors that they're looking into, but just know that they can be broadly divided into categories, looking at abnormal trophoblastic growth, abnormal cordis luteum function, markers of growth in fallopian tubes, and inflammation or peritoneal indications. Here's where you're really going to make your diagnosis, the ultrasound. This test has by far the highest likelihood ratio, 111, of any part of the workup you can do. 88% of ectopic pregnancies are identified by a lack of intrauterine pregnancy plus an adnexal mass, and the diagnosis is confirmed if you then see the yolk sac and the embryo in the ectopic tissue. The American College of Emergency Physicians recommends transvaginal ultrasound for all suspected ectopic pregnancies, regardless of the beta HCG level. While sensitivity is low when the beta HCG is less than 1,500, the specificity is still 96%. So given the limited downsides of ultrasound, it's worth at least taking a look. If your patient has undifferentiated abdominal pain, you might actually begin with a fast exam. Free fluid can be associated with both ruptured and unruptured ectopic pregnancies. If you do a fast first, you should then follow up with a more focused pelvic ultrasound. Transabdominal views might give you a good high-level view, but only identify an ectopic 35 to 50% of the time. Transvaginal ultrasound can make the diagnosis about 95% of the time. I'll walk you through the steps of a transvaginal ultrasound. First, you're interrogating the uterus for an intrauterine pregnancy. Pictured on the left is a viable intrauterine pregnancy. You can see the gestational sac, labeled here as a double decidual ring sign, with a yolk sac in the center. Notice how this is all to the side of the uterus rather than centered. On the right, you have a thickened endometrial stripe, which might suggest to you an intrauterine pregnancy, but you don't actually see that gestational sac or a yolk sac. There is, however, some free fluid surrounding the uterus, which might be a hint that there is a pregnancy somewhere else. One word of caution, while this has a thickened endometrial stripe, you can actually see endometrium in any of its phases, so seeing a different form does not rule in or rule out an ectopic pregnancy by itself. So I referenced how the gestational sac was off to the side, and that's really to differentiate an intrauterine pregnancy from a pseudosac. So this is a common misdiagnosis. The pseudosac is a little bit of fluid that's in the uterus. It's an oblong shape, and it's always centered in the middle of the uterus, not off to one side. That's what you're looking at in those top two pictures, and then for comparison, you can see a gestational sac in the third picture. If you see that pseudosac, you should still go looking for an ectopic pregnancy. So now that you've failed to identify an intrauterine pregnancy, you need to go find that gestational sac, but it's hard to know where to start. The easiest way is to start by looking for the corpus luteum. 85% of the time, the ectopic is on the ipsilateral side. Of course, the corpus luteum isn't necessarily straightforward to find. It can be cystic, solid, or hemorrhagic, so it might take a little bit of practice to identify this. If you're not sure what you're looking at, you could consider turning on color flow or Doppler, as this is a very vascular structure, so you will always see a ring on it, and that's what's pictured on the right. So if you found the corpus luteum, then the fallopian tube on that side is the logical next place to look for an ectopic pregnancy. On the left, you can see the ovary up top where you'd find the corpus luteum with an ectopic pregnancy below it. You can also in this picture appreciate free fluid to the right side. On the right, you have a zoomed in picture of the fallopian tube. The arrows are pointing to the gestational sac, and then there's an asterisk in the middle surrounded by the yolk sac. That's called the tubal ring sign. You might also see the tube with a gestational sac, but nothing inside it. That occurs about 40 to 45% of the time in tubal ectopic pregnancies. It's known as the bagel sign here in the US. You might also see a solid mass next to the ovary that's actually clotted blood. It would look somewhat similar to what you see on the left, but maybe a little more filled in. That would actually be indicative of a tubal abortion. So if you see any of these configurations, you have your diagnosis. But to be thorough, it's still recommended that you ultrasound the other fallopian tube to make sure you're not missing a second ectopic pregnancy. These pictures are just to further drive home that point. On the top left, you can see a uterus without an interuterine pregnancy, but you see fluid and clots in the cul-de-sac, which is where the red asterisk is. In picture B, you have a heterogeneous right adnexal structure, which is known as the blob sign. In C, you have color Doppler flow on, which shows flow and fetal cardiac activity, if I was playing this as a video. And then in D, this is actually the isthmus portion of the fallopian tube, but that white arrow again is pointing to the gestational sac, and that blue arrow is pointing at an embryo. So we've covered the tubal pregnancies, which are most ectopic pregnancies, pretty well. But I want to take a minute and review the other locations that these can implant and what you'd be looking for on ultrasound. So first, this is an interstitial ectopic pregnancy or cornual ectopic pregnancy. This can be very tricky to differentiate from an intrauterine pregnancy because its implantation is on the periphery of the uterus. What you're looking for to differentiate this is an endometrial line sign, which is what that blue arrow is pointing at. It's a little bit subtle, but what this is a connection between the gestational sac and the endometrium that should be feeding it. I've included a little diagram on the right for reference. Here we have a cervical ectopic pregnancy, which is very, very rare, but definitely a life-threatening diagnosis. This can often be confused with a spontaneous abortion in process, and so that's the most important thing to differentiate it from. Hints that this is actually a miscarriage rather than an ectopic pregnancy would most obviously be a comparison to a prior ultrasound. If you had an ultrasound showing a well-implanted embryo, say 2 weeks ago, and now it's moved into the cervix, this is unlikely a new implantation spot. Similarly, if the similar Oz is open, that's indicative of an abortion in process. And you can try the sliding sign. So you take the intercavitary probe and you push on the cervix. If that's able to move the embryo, then that implies that it's not well implanted or attached to anything. And that also would hint that this is a miscarriage. Here's a situation that's actually increasing in prevalence with the increase in the number of C-sections being done. It's a C-section scar ectopic pregnancy. So during a previous or after a previous pregnancy, as the scar was forming, there was a little defect in the scar that formed a pocket. And unfortunately, in this case, that's where the embryo chose to implant. So you're looking for the ectopic pregnancy right along that scar line, which would be above the Oz. Sometimes these might look a little like a cervical implantation, but you just need to compare to the Oz to differentiate them. Interestingly, as this pregnancy develops, it can develop towards the into the uterus or outside of the uterus. And then one more just worth mentioning, this is a heterotopic pregnancy. So this is when you have a viable or non-viable intrauterine pregnancy coupled with an ectopic pregnancy. These are exceedingly rare, about 1 in 30,000, but the rate is higher in assisted fertility situations. So generally speaking, if you see an intrauterine pregnancy, you have ruled out ectopic, but in this special subset or in patients who just don't look too sick to be explained by just the intrauterine pregnancy you saw in ultrasound, you might want to keep digging for an ectopic. In terms of management for these patients, it will really depend on what they look like when they get there. If they're stable, you'll do the workup that we've already talked about, but if they're unstable, you'll treat them like any other hemorrhagic shock patient. Go through your ABCs, get 2 large bore IVs, send out a type and cross, but don't wait to start administering fluids and O-negative blood. This is a good time to use a urine pregnancy rather than a serum pregnancy test, and get OB involved early because they will likely need to go to the OR. For your other patients, their definitive treatment and dispo planning can be divided into 3 big categories: expectant management, medical management, and surgical management. And we'll go through all 3. So expectant management is reserved for your most reliable, stable patients. This will require a lot of outpatient follow-up. So this needs to be a woman who has good social support and good access to the medical system. The beta HCG should already be low and falling. They should have a low progesterone level and a gestational sac that's so small it can't be located on ultrasound. Additionally, this patient should be hemodynamically stable and not in pain. The plan here will be to have them come back in 2 days for a repeat beta HCG, and they'll repeat that 3 or 4 times and then transition to once weekly beta HCGs until the beta HCG is less than 15 or other sources will say 0. Importantly, this can take up to 3 weeks to happen, so you're really committing this woman to a lot of outpatient follow-up. Of course, you'll also give her stricter return precautions for between those visits, as this technique has about a 72% overall success rate, with the rest of them converting to medical or surgical management. So medical management is generally accomplished with 1 dose of IM or IV methotrexate, 50 milligrams. This is a folic acid antagonist that you might already know from its use in neoplasia, psoriasis, and rheumatoid arthritis. This is appropriate treatment for someone who has no hemodynamic instability and also is not in significant pain. The ectopic pregnancy needs to be small, less than 3 centimeters in size, without fetal cardiac activity, and the beta HCG should be relatively low, less than 5,000. It's appropriate for women with no significant comorbidities, and notably, methotrexate has a pretty long list of contraindications. So, there are a lot of women who wouldn't be appropriate for this, including those with renal failure, alcoholism, peptic ulcer disease, immunodeficiency, active disease of the lung, kidneys, or heme system, heterotropic pregnancy with a viable intrauterine pregnancy, those who are breastfeeding, and those who are, for other reasons, unable to follow up as an outpatient. So after you give the initial dose, you would want to repeat their beta HCG in 1 week. If it's not falling, you can actually repeat the treatment 1 more time. Notably, after a week, a lot of women who receive methotrexate will report pelvic pain. That's thought to be a possible hematoma forming where the ectopic was, which is not in itself dangerous, but these women can also still suffer a ruptured ectopic pregnancy. So if a woman who received treatment for an ectopic pregnancy comes in complaining of abdominal or pelvic pain, it's still worth repeating an ultrasound for her. Finally, we move on to surgical management. Technically, this is the gold standard for both treatment and actually diagnosis, as it's the only way to actually visualize the ectopic pregnancy. There are a few different techniques here. You can do a salpingectomy or a salpingostomy, a laparoscopy or a laparotomy, depending on what the woman looks like when she gets there. The overriding indications for a surgical procedure are those with rupture, with hemodynamic instability, with persistent bleeding, or those who just do not want to undergo medical management or are unable to perform the follow-up necessary. Salpingectomy is generally used when somebody is done childbearing, has severely damaged tubes, or has recurrent ectopics. Salpingostomy is generally done for those with an unruptured, less than 5 centimeter ectopic, or those who already do not have a contralateral fallopian tube and do aspire to have children in the future. Laparotomy is generally chosen over laparoscopy when the patient is hemodynamically unstable or if they will be a difficult surgical candidate for other reasons. So that's all of the new material we'll be going through, and it's a lot of information. So I want to summarize it as ectopic pregnancies are a small percentage of total pregnancies, but there's a high prevalence in women presenting to the emergency department during their first trimester with abdominal pain, bleeding, and a missed period. Your focus is really on stabilizing the hemodynamically unstable patients first, and then get an ultrasound for everyone you can, as that's the best way to get the diagnosis. When you're ultrasounding, look for the corpus luteum because that will give you a hint where to look for the gestational sac. 85% are on the same side. And then most women will have either methotrexate or surgery as their definitive management, with a small portion of women able to go home and follow up as an outpatient. I hope you found this information helpful. Please don't hesitate to reach out with any questions you have, and I look forward to going through cases with you next week.